The broadcast is now starting. All attendees are in listen-only mode.
Hello, thank you for joining Raleigh Orthopaedic's webinar. Today, Raleigh Orthopaedic's board-certified fellowship-trained sports medicine surgeon, Dr. Matthew Boes, will be discussing shoulder pain and injuries. If you have a question during the webinar, please type them in the questions box, and we hope to answer all questions at the end of the presentation. And here is Dr. Matthew Boes to begin the presentation.
Well, good morning or good afternoon to everybody. I'm glad and happy that you've joined us here. I'm one of the shoulder doctors at Raleigh Orthopaedic, and I'm going to talk a little bit today and give a little bit of an update on the rotator cuff, what exactly the rotator cuff is and why it's important and why it's something that we really need to take seriously when we talk about injuries or potential problems with it. My subtitle there, the good, the bad, and the ugly. At first, I want to stress here that there's definitely good with the rotator cuff. I'm not going to focus so much on that today, but the treatment of rotator cuff tears is very successful. Over 85% of people have good to excellent results, and it's important to keep that in mind. What I'm going to focus a little bit today on is some recent research that's helped us understand the long-term effects of untreated rotator cuff tears, what some of the bad things that can happen if rotator cuffs are poorly treated or untreated, and potentially even some ugly things that can happen that we really want to try to avoid as we go along. Bear with me for 1 second. There we go. Just as an introduction, it's important to remember that the rotator cuff is critical to shoulder function, and I'll show you why that is in a few slides. It's also important to remember that there's no replacement for the rotator cuff. I kind of put that in quotes because people who have rotator cuff problems are generally in the age group that they may also be having problems with hip or knee arthritis. And those are relatively straightforward problems that we can take care of with some type of replacement or resurfacing procedure that really has excellent early outcomes and good long-term results. There's no analogous procedure for the rotator cuff, and so it's important that we preserve the native rotator cuff as much as possible. And as I stated, there is some recent research that shows what the negative long-term effects are with untreated rotator cuff tears, and this has kind of altered our treatment recommendations to a certain extent in certain groups of patients, the goal being to try and keep the native cuff functioning well as long as possible. Well, what exactly, let me go back here. There we go. What exactly is the rotator cuff? Well, if we look at the shoulder joint's a ball and socket joint. The top of the arm bone forms this nice big ball, and that fits into a tiny socket off the side of the shoulder blade. And that's normally a good situation. Like I tell patients, you know, it's a nice big ball and a nice shallow socket. So the arm joint, the shoulder joint is very unconstrained, and it leads to us having great range of motion. We can bring our arm up overhead, we can bring it out to the side, behind our back, etc. The one downside to that is that because it's so unconstrained, it's a little bit unstable. And what we have to counteract that is the muscles of the rotator cuff. Now, the rotator cuff is made up of 4 muscles and their attached tendons, and it gets somewhat confusing when we talk about rotator cuff muscles versus rotator cuff tendons. Essentially, those terms are used interchangeably. The muscles all arise off of the shoulder blade, and they start off as muscles, as you can see here, and as they come out to the side, they form these white tendons. Now, these white tendons kind of interweave and interdigitate, and they all attach to the outside part of the arm bone in the front, the top, and the back. And when we talk about what the rotator cuff does, as outlined in this red line here, it forms this 3-sided sleeve or cuff of tissue that surrounds that arm bone at the top and stabilizes that ball in the socket. And we can see that here in a couple different planes. Those muscles, just like the red arrows show, keep that ball centered in the socket. And that's important to give us a normal fulcrum or rotation point so that larger muscles can raise our arm up. You can see that here where the ball is stabilized at a neutral point in the socket, and larger muscles such as the deltoid, the latissimus, or the pectoralis, etc., raise the arm up and put it anywhere we want to in space. And so that's a critical function of the rotator cuff. Well, why are these important? Well, basically, that function is utilized in all types of motions that we do in our daily lives, lifting overhead, going behind the back, picking up children or grandchildren. So we use it all the time. And actually, when we talk about rotator cuff tears with patients, a lot of times they'll say, oh, well, isn't that something that happens in baseball players? And it's true that pitchers and ball players get problems with the rotator cuff, but it's actually a tiny fraction of the people we treat for these problems. Well, how do these tears develop? Well, you can certainly get them from traumatic injuries, say a fall or a dislocation of the shoulder where the tendons rupture off the bone. But most of the time, it's some degree of tendon degeneration or wear and tear that goes on. And this occurs as we age through all the tendons in our body. And I tell people that it's kind of like the analogy is with the shoelace, where a shoelace doesn't just all of a sudden break. It kind of frays over time and then and slowly splits as more and more fibers get ruptured. And the same kind of thing happens with our tendon. It has to do with some changes in blood supply and some intrinsic changes to the tendon, et cetera. Well, how common are these? Over age 60 years, up to 50% of people can have rotator cuff tears. 50% of people who have a tear in one shoulder will have a tear in the opposite shoulder as well. And what's interesting to note is that several studies have shown that, again, going to these age-related incidents of rotator cuff tears, in people over 70, even without shoulder pain, if you take people just randomly off the street and you evaluate them with either an ultrasound or an MRI, it's been found that over 43% of people age 70 or over will have evidence of rotator cuff tearing. So it really does increase with age. Well, we now know what happens with the rotator cuff is, again, that your chances of getting a tear increases with age. It often affects both shoulders. And more recently, we've gained an appreciation for the fact that these tears, once they start, tend to increase in size. And there's this progression of the tear which can occur over time. Most importantly, however, is this evidence that shows that there's really no chance that that rotator cuff will heal without treatment. And by heal, I mean reattach itself back to the normal place where it should be attached on the bone once there's been a full tear. And I'll show you what I mean by that in the next few slides. So just to orient you, this is looking down at the right shoulder. The head would be over this way. The outside part of the arm is over here. The front is toward the top of the slide, and the back is towards the bottom part of the slide. And this is the top rotator cuff muscle, and it's the front outside part of this muscle that usually is the one that's initially involved in this wear and tear process. And it starts off with some irritation and degeneration, and then this can progress to some partial tearing, where you get partial failure of certain fibers, but a few are still attached. Remember that analogy with the shoestring. This progresses to full tearing. Now, once this happens, the tendon is completely detached from its normal attachment site on the bone. And you have the pull of the rotator cuff muscle, which is constantly pulling that tendon edge away from the bone. The tears tend to get larger over time, as we discussed, and a greater portion of the tendon can be involved. And in fact, you can get to the point where multiple tendons are involved. This is a problem because as the tear gets big enough and it extends to the front and the back part of the shoulder, you lose that sleeve or that containment function of the rotator cuff, and therefore you can lose its function as a stabilizer and as a centering point for the shoulder, and that's where you can get real loss of shoulder function and loss of motion. This is a good example of that here. This is a gentleman who's got a normal functioning rotator cuff on the left or the right side as you see it here. You can raise his arm up here. And he's got a large rotator cuff, which has been long-standing on the right. And you can see when he goes to fire to lift his arm up, there's no fixed rotation point there, and he can't bring it up overhead. Now, I don't want to overly alarm people. This is not something that happens with all rotator cuffs. This is something that can happen over time. But we now know that there's a general progression towards this once a rotator cuff tear occurs. We don't know how long it takes for that to happen, but clearly this is what we want to prevent. Once it gets to this point, there's not a lot of good options for treating that. In addition, a lot of evidence has shed light on what happens to the actual health of the muscle or the tendon as a result of having this full tearing, where the tendon is torn off from the bone and detached. And in this situation, you got to remember that the muscle's not functioning normally. It's not doing its normal physiologic stretching and contractions, that kind of thing. So you can develop muscle scarring, where actually the normal muscle tissue is replaced by scar tissue, and this can disrupt the normal muscle function. You can also get shrinkage and atrophy just from disuse, where the muscle gets weaker. In addition, the tendon loses its stiffness, and actually as it pulls back away from its normal attachment, it loses its kind of pliability or its elasticity, and you really can lose the ability over time to stretch that tendon or to free it up and to get it back to its normal position on the bone when you try and do a repair. And actually some of these tears can become irreparable. And that's obviously what we want to prevent. What we know is that these muscle changes are largely irreversible. Again, that's if you don't treat the tear, and these can, over time, as I showed you in that previous video, can lead to permanent loss of shoulder function. Well, what do we do about preventing and managing these, and how do we know if someone has a rotator cuff tear? Well, the predominant symptom is going to be pain. And pain is usually felt at the side of the shoulder. You can get this sensation that it radiates down to the elbow, and sometimes people can describe a radiation even into their forearm or their hand. The pain is generally made worse by positions of the arm which tend to press on that torn and inflamed area when you bring your arm, such as when you bring your arm up or if you bring it behind your back, reach to the side, that kind of thing. In addition, a very common complaint is pain at night, and people will describe that if they roll over onto their shoulder at night, it'll actually wake them up. And when we're examining someone, we look at their range of motion, we look at their strength in different positions, and then there's special tests that we can do to try and isolate each individual rotator cuff muscle and test it individually and look for evidence of irritation or weakness of these muscles. It's important to note, though, that just based on talking to the patient about their symptoms and examining them, it's almost impossible to pick up whether or not a patient has a full rotator cuff tear based on the clinical evaluation alone. And we almost always order some type of advanced imaging, either an MRI or an ultrasound. And we'll also get x-rays at the time of the initial evaluation, and that's important to look at the structure of the bones and the joint spaces. The issue with the x-rays is that it doesn't show soft tissues, so it won't show the muscle or the tendon, and you need to do some other kind of imaging for that. Two main types are an MRI and ultrasound. The MRI is great. It gives you very detailed images. The downside to it is that it's very expensive, and you have to sit in this tube sometimes up to 25 or 30 minutes to get these images, and that can be uncomfortable and not a very pleasant experience for the patient. Now in Raleigh, we're very lucky because we have several radiologists who are skilled at doing ultrasound. Now ultrasound, you don't get as detailed images, but it essentially tells us what we need to know. It's much less expensive. It'll tell us whether or not you have a full rotator cuff tear or not. And really, it's as simple as just going into the office and having someone place a probe on the shoulder. And oftentimes, they'll do both shoulders simultaneously. So that's generally what we'll order. Well, what are our goals of treatment? As always, we want to alleviate pain and maximize function. That's always true. But what we've begun to focus more on, particularly with this natural history data and the data we've gotten on changes in the muscles and the tendons, is we want to try and intervene in terms of treatment before these irreversible changes can occur. And that's the way we can maximize long-term shoulder function. In terms of non-operative treatment, these are generally now reserved for patients who have tendinitis or bursitis, or most patients with partial tears or some type of partial disruption of the tendon. Remember the analogy with the shoelace. In these situations, the tendon's not fully detached from the bone, and so you're not, developing the progressive changes in terms of size, and not getting those negative effects from disuse on the muscle. So in these instances, we try and maximize non-operative treatment. And that may consist of some anti-inflammatory pills to help decrease inflammation around the rotator cuff. Oftentimes we'll recommend cortisone. It's a very powerful anti-inflammatory that we put in that area, and it's good for pain relief. And then we'll recommend some type of rehabilitation. What I usually tell patients is I want them to learn how to do exercises for the rotator cuff properly, So we'll send you for 1 or 2 therapy visits so they can work with you a little bit. And then for the most part, once you know how to do this stuff properly, you can do it at home on your own. And the goal of this is to restore the function and the strength of the rotator cuff. And oftentimes, if there's an area that's kind of worn out, normal areas of the rotator cuff can kind of take over for that to a certain extent. Now, what's the rationale for surgical treatment? Well, essentially, as I described, and as I went through in those progression slides, there's no evidence that these tears will heal on their own. And by that, I mean no evidence that the tendon will go back against the pull of that muscle and heal in its normal position on its own. And again, we want to prevent the irreversible changes that can occur in the muscle as a result of having a tendon detachment. So in most cases now, we're getting more aggressive with full tears and recommending surgery. And this is particularly true for patients who are active, who want to remain active down the road, have full use and strength of their shoulder, particularly in the case of if it's their dominant extremity. The thing to remember is that when tears are smaller, they're generally easier to repair, and the results, if you look at the results of smaller tears compared to larger tears, are generally much better for smaller tears than larger tears, with the rehab being somewhat quicker as well. So that's why we've changed how we've approached these somewhat to get a little bit more aggressive with treating these tears. So in summary, I want you to remember that over 85% of people have great success with treatment for rotator cuff tears, so there's definitely good. What I wanted to highlight today is that there is bad things associated with rotator cuff tears, i.e. they get bigger over time, you get that muscle change, those muscle changes like we discussed. And what we want to avoid is the ugly, which when left untreated over time, these changes can lead to some permanent loss of shoulder function. And that's why I'd like to stress that, you know, if you're thinking that you have a rotator cuff problem, you're concerned about that you seek appropriate treatment for it, and that's instituted as soon as possible. So in summary, be good to your rotator cuff. Just like Elvis, there's only one original. And thank you very much for your time, and we'll take some questions.
As Dr. Boes said, we will be opening up to questions now. If you will type your questions into the chat or into the questions box, we will answer the questions as they come in.
All right. First question is, can you differentiate rotator cuff tears from frozen shoulder? Well, rotator cuff tears and frozen shoulder are essentially two distinct things that happen in the shoulder. Frozen shoulder is also called adhesive capsulitis, and it's a condition that involves the joint capsule of the shoulder. Every joint in the body is surrounded by a capsule or a thin layer of tissue which contains the joint and the ligaments that help stabilize the joint, as well as cells that produce joint fluid and lubricate and nourish the joint surfaces. Now what happens in frozen shoulder, for reasons that still aren't really completely understood, that joint capsule becomes inflamed and very stiff, and this leads to pain and loss of motion in the shoulder. The rotator cuff tendons are actually outside of the joint capsule, and they're kind of above, in front, and in the back of the joint capsule. And injuries to these tendons, like we've discussed previously, can disrupt the normal mechanics of the shoulder and can lead to pain and irritation, as well as loss of motion, in addition to loss of strength. So they're somewhat different in terms of their etiology. How do I know? The next question is, how do I know that the pain in my shoulder is from my rotator cuff? And that's an excellent question, and what I was trying to get at to a certain degree with how we evaluate these. Generally, the pain from a rotator cuff tear is classically felt kind of at the outside part of the shoulder, okay, just off that bone that you feel on the top there and into your deltoid muscle. And it's worse when you do things like bring your arm up overhead, reach for a coat behind your back, go to tuck your shirt in, that kind of thing. And classically, that pain can kind of radiate down to the elbow because it goes along the course of the bursa that sits over the rotator cuff. Now, in order to figure out if it's an actual tear, like I said, you really need to, except in cases where people have very large tears and they can develop some significant weakness that's obvious when you examine them. It's very difficult to determine if someone has a small, full-thickness tear. And in those cases, what we generally do is we kind of localize, and we know the problem's coming from the rotator cuff. The question that I read before is applicable because sometimes people think that they have a rotator cuff problem, and actually what they have is frozen shoulder. And so obviously we want to localize the problem to the rotator cuff, and then we need some type of imaging that rules out and that makes sure it's not a full tear. And again, what we generally recommend is an ultrasound, just because it's a little bit quicker, it's easier on the patient, and it's cheaper. Next question is, what is recommended over-the-counter medicine for pain? Well, what we would recommend is that you take some regular anti-inflammatories. And what I usually tell patients to start with is to take just over-the-counter, say, Aleve or Advil or Motrin, whatever works for you best. And the reason I say that is because there's definitely instances where certain medicines work well for one patient but don't work at all for another patient. So you may need to experiment a little bit. The important thing is that you take it regularly for a period of time, either 7 days or 10 days, and you get the medicine built up in your body so it can work on your shoulder. So, for example, if you take Aleve, what you take is 2 of those Aleve tablets twice a day, and do that straight for 7 days and see where you are. Or ibuprofen, say Advil or Motrin, you take 3 pills 3 times a day in that situation. And the reason why I say take it just for 7 to 10 days is oftentimes that little brief course of therapy is enough to decrease your pain and get you moving again, and you often don't need to take the protracted dosages that can lead to more side effects. Let's see here. Next question. Oh, this is a great question. I have experienced the painful symptoms you described, but was told that I have a partially torn labrum. How is this different from rotator cuff damage? It's a little bit difficult to show you this without a diagram. What I would direct you to is go to www.aaos.org. That's the American Academy of Orthopaedic Surgeons website. There's a patient education section there, and what you can search for is SLAP, capital S-L-A-P tears, and that's the labral tear you're describing. That is a tear of a structure that's inside the joint. It's almost like a gasket-type rim that surrounds the shoulder socket and kind of deepens the socket and serves as attachment site for various ligaments, as well as for one of the tendons from the biceps muscle on top of the shoulder. Now, generally those labral tears, as you said here, involve disruption of where that biceps tendon anchors into the top of the socket, and that's why they cause pain and dysfunction. It's different from a rotator cuff tear because it's in a different anatomic area. But I think if you go to that website, it'll show you some good pictures and have a good discussion about that for you. Okay, here's another good question. Do you have a set of exercises that one can do to rehab what might be a tear of the rotator cuff? That's an excellent question. What we generally recommend is exercises in front of the plane of the body, okay, not bringing your elbow back behind your shoulder blade, and below shoulder level. And there are various rotation exercises that you can do and exercises coming out to the side and in front of your body that will strengthen individually the muscles of the rotator cuff. What I generally recommend is that people go to at least 1 or 2 therapy appointments, and the reason for that is that it's very easy to do these wrong, and it's helpful to have someone instruct you in how to do it. Make sure you're not doing them incorrectly, because it's very easy to actually irritate the problem if you're doing it incorrectly. So that's what I recommend, is that you seek some instruction from a physical therapist. And if you call, we can certainly help you with that. Next question is, How are tendons reattached to the bone, i.e. how invasive is the surgery and how long is the recovery? This is a good question that I guess relates to how we treat these surgically. Most rotator cuff repairs are now done using a technique called arthroscopy. And this is the procedure where through tiny incisions, a tiny camera that's attached to a high-definition monitor is used to see inside the shoulder, again, through small incisions, which these are, less than a centimeter long. Special instruments are then used to repair the tendon through these small incisions. The tendon is reattached to bone using special suture anchors that have stitches attached to them. The anchors are placed into the bone and they can stay there permanently, and then the stitches are passed using a variety of techniques through the edge of the tendon and then tied down using a special tying device. Usually about 3 to 5 small incisions are made, and anywhere from 1 to 4 suture anchors are used. However, this can vary considerably with the size of the tendon, or with the size of the tear, rather. The important thing with this is to remember that the suture anchors and the surgery is only holding the tendon back to where it needs to heal on the bone, and it's not strong enough to allow you to start moving your shoulder right away. We know from research that it takes 6 weeks for the tendon to even start healing back to the bone, and so during that time the shoulder is protected in a sling to prevent any abnormal stress on the repaired tendon, which can cause it to tear away from the bone again. The sling is generally removed at 6 weeks, and then graduated therapy is begun. In general, it's 6 months before you can use the arm for high-level activity. That means prolonged stuff overhead with good strength. People are generally much more functional well before that. And what we say is that it can be 12 months or more for you to get complete recovery after the surgery. It's important that we differentiate that. This is a lot different from the recovery period that you get after a hip or a knee replacement or for healing of most fractures. This is generally a lot slower than the recovery for those types of conditions, and it's important to remember that. And a lot of times it just has to do with the healing capacity of these tendons, because in order for them to tear, there's been some loss of the blood supply there, and that loss of blood supply can affect your healing.
Okay. Thank you, Dr. Boes, for the wonderful presentation. Unfortunately, we are out of time for any additional questions. We thank you for your time in joining us during this wonderful webinar, and the recorded webinar will be posted on the Raleigh Orthopaedic website at www.raleighortho.com. Thank you again, and have a great afternoon.